this is the actual topic. So before that, we will try to know that what are the myths in regarding to this topic. So people used to think that it is not true that you lose a tooth for every pregnancy. That you lose a tooth every time there is a pregnancy, there is a tooth loss, and calcium is taken from the mother's teeth for the baby's growth, and mother's diet should be adequate enough. And otherwise, the mother's bones will become weak, and the whole calcium is taken away, and the whole all the teeth of the mothers are lost. These were the two myths which were regarding the pregnancy and the teeth. So when we begin with the actual topic, we have the periodontal disease and adverse pregnancy outcomes. Now, periodontal disease and adverse pregnancy outcomes, we have most of the adverse pregnancy outcomes are preterm birth, low birth weight babies, preeclampsia, miscarriage, intrauterine growth retardation, and premature rupture of the membrane, and the most important, small for gestational age. This is one of the most important. Now, when we consider the relationship between the periodontal disease and adverse pregnancy outcome, we have the most common authority, which is Offenbacher. For centuries, we had Offenbacher, who has done a lot of work, and Offenbacher was the most important authority because in 1996, Offenbacher has introduced the terminology called as periodontal medicine. So Offenbacher has started a terminology called as periodontal medicine in 1996 after his first study. He and his associates realized that pregnancy and periodontal disease have a bidirectional relationship, and periodontal disease could be considered as a risk factor for adverse pregnancy outcome. There was one more study which was done before that by Galloway, who suggested that the disease has more than just an association but also contributes. So you have to be very clear in understanding that what is the association disease and what is the causal factor. Some conditions you have causal factor, some conditions you have association factor. Now Offenbacher has suggested that how the disease happens and how the periodontal disease is responsible for the foci of infection, where it releases the endotoxins, which are lipopolysaccharides, which will cross the placental membranes across the bloodstream and elicit the production of inflammatory mediators and leads to the disease. It basically leads to preterm parturition. Now, this is a very important classification on low birth weight. The only terminology you are aware of is low birth weight. So low birth weight is less than 2.5 kgs if the baby is born. So normally we consider the normal birth weight is considered to be 3 kgs, 3000 grams. Now, if it is less than 2.5 kgs, it is called as a low birth weight. If it is less than 1500 grams, it is called as very low birth weight. If it is less than 1000 grams, it is called as extremely low birth weight. Okay, that is very important. So these are the three conditions which are low birth weight associated. Then you have preterm birth. Preterm birth is classified into normal gestation, preterm birth, late preterm birth, very preterm birth, and extremely preterm birth. So we consider the normal gestation to be 40 weeks. Preterm birth is considered less than 37 weeks. Late preterm 34 to 36 weeks. Very preterm less than 32 weeks. And extremely preterm less than 28 weeks. So this is how we subclassify the preterm birth. So when we consider preterm low birth weight, when I say preterm low birth weight, it is less than 37 weeks of gestation with less than 2.5 kgs of a baby which is born. And this is a very important definition of preterm low birth weight. You have risk factors and lot of risk. This happens more commonly in African American heritage people, low socioeconomic status people who cannot undergo a good prenatal care, drug abuse, alcohol and tobacco use, hypertension, diabetes, and patients with multiple pregnancies. So when the patient already has undergone multiple pregnancies, then the chances of the parturition is complicated or with lot of adverse outcomes. So it is possible that the genitourinary and the periodontal infections may adversely affect the pregnancy outcomes. That is very important. There are various risk factors for that. You have environmental factors, that means I've already told you antenatal care, nutrition, habits, genetic factors, and obstetric factors. All of these factors will lead to the disease. Now, what happens actually is because of these factors, which are genetic or obstetric or anything, these factors will lead to infection or toxic exposure to the fetus. And because of the other factors, all these factors will lead to preterm rupture of the membranes and a premature labor. Basically, it's a premature labor. That means premature labor is contributing to the various membrane ruptures and the delivery or the parturition. This figure is an important classic figure from Journal of Medical Life. Then this is how we understand the physiology and the pathology of the preterm low birth weight. Now, when there is an infection, you have an endotoxins, and you know the most important endotoxin for periodontal disease is lipopolysaccharide. It releases the endotoxins and the other microbial factors which will lead to inflammation. There is inflammation which leads to complement activation and macrophages and TNF. Also, there are a lot of inflammatory mediators which are released. They are also there. So, and because of which they will be a normal delivery also needs an oxytocin which is stimulated by the pituitary. Even that release to the contraction of the uterine and there will be a premature labor. So, what exactly happens is when all of these things are acting, there will be premature delivery. So, you have to understand the main concept or the pathophysiology. Now, I have explained that there are three mechanisms which are accepted by Offenbacher, which explains the three mechanisms are the bacterial spreading, the inflammatory products dissemination, and role of feto-maternal immune response to oral pathogens. I'll explain one by one. This is the most important, the core of the topic. You have bacterial spreading, that means the bacteria which are present in the oral cavity. We can attribute it to P. gingivalis or P. intermedia. Now, these bacteria spread all along the systemic circulation and can penetrate into the placenta and can enter into the amniotic fluid. They found Fusobacterium nucleatum in the amniotic fluid. They found P. intermedia in the amniotic fluid. So that is bacterial spreading is most important. Then you have the inflammatory products. That means all the inflammatory products which are released from the periodontal disease or from the gums. That products from the blood circulation can cross the placental membranes. And when I say products, I include interleukin 1 beta, prostaglandins, TNF, these products. And they may also go and indirectly stimulate the liver, and liver may release acute phase proteins, and that may also stimulate the premature. Then, the most important, when we consider preterm low birth weight per se, we need to understand that the role of feto-maternal immune response. You may ask me that, why all the females are not having this problem? Why only few people have? There are so many periodontal disease related females who have got the disease but may not have preterm birth. Why is it like that? Because of the immune response. Some females have a different type of a genetic or a phenotypic response which are hyper responsive in the nature. So as these interleukins are hyper responsive, they are too sensitive to the bacteria, and then the maternal immune response is very, very hyper responsive. Immune reaction is very exaggerated, which will relate to that. So what happens is the prostaglandins, and prostaglandins are most important to cause the labor or the uterine contractions. This is how the three mechanisms explain the role of the disease in the adverse pregnancy outcome. This is a very important classic diagram which shows the possible mechanisms, and this was again contributed by Offenbacher in 2013. Now, Offenbacher has explained, as you can see, that there is a infection, there is a chance of the bacterial products and the pro-inflammatory cytokines which are released, which may directly enter into the placenta, as you can see, or go to the liver and release acute phase proteins. So when they enter into the placenta, what they cause is a chorioamniotic infections in the membrane, which are responsible for the inflammatory mediators in the placenta. Now, all these infections and all the bacteria are released inside. Then there will be an inflammatory response, production of the prostaglandins, membranes will rupture, and there will be a premature labor. One more thing, the infections can also lead to a lot of growth factor release and a lot of multiple platelet thrombi which are formed, which will also lead to preeclampsia. I will discuss about preeclampsia in the later half of the presentation. Then you have miscarriages which happen. And then the most important, I hope you remember the first slide which I showed you, that there is something called as bacterial vaginosis. That means few females who have got bacterial vaginosis, that means the infection of the vagina. Those infections can retrograde enter into the uterus and can lead to the placental damage and can lead to the infection. So chorioamniotic infections or bacterial vaginosis or periodontal disease are causing lot of infections, which is leading to, basically nutshell is the chorioamniotic infections, and the amount of inflammatory mediators will increase and the disease will happen. That's how it happens. And the most important, the landmark study is by Offenbacher 1996, human study conducted, case control study on 124 pregnant or postpartum women, and he has shown a significant relationship. This is very important and you cannot afford to forget the name of Offenbacher. Offenbacher was a person who has coined the term periomedicine, but unfortunately expired some 15 days back. I hope everyone is aware of Offenbacher. This is one important thing, just for the interest of the postgraduates, I have added that there is something called as the amniotic fluid sludge. It was given by William Costerton. I think Costerton is also considered as one of the pioneers of biofilm. Costerton, there's a textbook on Costerton for biofilm, and there's a detection of P. gingivalis in the placenta and Fusobacterium nucleatum in the fluids, which have buttressed the concept of oral infections and pregnancy. There are severe studies I have shown in the presentation. The green indicates the positive and the red indicates the negative. So the green indicated studies, Offenbacher, Lopez, you have got Jarjora, Marine, Malinora. A lot of people have done on positive studies, and the negative studies are also there. They are also definitely negative studies, but then you may also, most important negative study is by Vetur et al. And one more important is Srinivas et al. 2009. Vetur 2006 are two more, and there's one more Mikhailovich. There are three classic studies which were done on negative aspects of the studies. You may ask again, then why there is so much of disparity among studies? So the answer is because the selection of the patient. Some are case control, some are cohort, some are RCT. We cannot confirm. One explanation for their findings is poor control. You don't know how to confirm the factors, and you don't know how much history the patients are revealing. That is why there is a lot of disparity in systematic. Then this is a very, very important, the last meeting happened in 2013. You have periodontitis and adverse pregnancy outcomes. It was consensus report of the joint European Federation of Periodontology and American Academy of Periodontology workshop on periodontitis and systemic disease. A very good volume for postgraduates to read. And that has given a lot of information regarding this, and it has supported, it was given by Sands et al. It was a recent one. Working committees has opinion that observation studies have provided an evidence, and there are direct and indirect effects which reach the fetoplacental. Direct means the direct bacteria will go inside the placenta and the amniotic fluid. Indirect means to inflammatory. So broadly you classify into two effects, direct and indirect. Every female patient, and has reported some guidance that every female patient in a childbearing age should go or intended to go for a prenatal counseling, prenatal care, and periodontal therapy has to be done if the patients are having existing disease. This is one of the most important, Scanapico 2003 Annals of Periodontology. It also said that periodontal disease is a risk factor, but causality is not clear. Then periodontal disease and preeclampsia. So then you may ask me, what is preeclampsia? Preeclampsia is nothing but, in normal words, it is pregnancy hypertension or a gestational hypertension, but it is not a normal hypertension. It is a hypertension with proteinuria. So when the hypertension is accompanied with proteinuria, it is called as preeclampsia. Now, preeclampsia is also a very distinct disorder with a lot of issues, and preeclampsia happens because of the same reason that there's a lot of inflammation in the placenta, there's a lot of inflammation in the amniotic fluid, in the sac, and those will lead to systemic spread, and a lot of things will happen, which leads to vasoconstriction all over the body and hypertension happens. That's how what is preeclampsia. Preeclampsia is the terminology which is used for gestational hypertension. If the pregnant female is already having hypertension, you cannot say it is preeclampsia. If the hypertension happens in second or third trimester during pregnancy, it is called as preeclampsia. Now, preeclampsia, severe and progressive maternal periodontal disease during pregnancy, is associated with very high risk of preeclampsia, and that was given by Bogus 2003. A higher proportion of the preeclamptic women were infected subgingivally with lot of periodontopathic bacteria. This is one of the systematic review in 2010. It's given by Kannan, and he said that preeclampsia is associated, but none of them have given 100% proof. There is one more in 2013 by Slograstra et al., and they also have given a positive association, but a very weaker risk of preeclampsia. Now, role of periodontal intervention in reducing the adverse pregnancy outcomes. And then the most important person was McAlowis. McAlowis has given a negative feedback. I have told you, if I'm indicating red, it means negative. McAlowis 2006 has said that if I do SRP, if I do flap, if I do any treatment for a pregnant female and try to reduce the adverse pregnancy outcome, they're not going to help you out. But then the same year, a great personality, Offenbacher, has given an editorial board review on this paper, and he said that the answer is premature. You cannot commit, because there are positive and negative associations. As I said you, McAlowis 2006, Srinivas 2009 have said negative association studies about this concept. Now, this is a little diverted. Actually, I'm not supposed to talk about this, but just for the awareness of the undergraduates and for the need-based people. Periodontal manifestations of pregnancy, there are two manifestations of pregnancy. One is pregnancy gingivitis, other one is pregnancy tumor. Now, pregnancy gingivitis, if you remember, it is conditioned, both of them are conditioned enlargements, and pregnancy gingivitis is very special because it happens only in the marginal gingiva. You can see the figure, you can see the whole margins are involved. So, pregnancy gingivitis has got a lot of margin involvement, and all the margins are involved with pregnancy gingivitis. It is a marginal gingival inflammation. Then you have pregnancy tumor, which is purely a type of pyogenic but happens in pregnancy, and pregnancy tumor is attributed to pregnancy because of its hormonal imbalance. It begins at the month, maybe the end of second trimester or beginning of third trimester, and enlarges. It is magenta or reddish color. You can see the figure. It is magenta or reddish color. You can see in the figure the magenta and the reddish color here. You can see how flattened the surface it is. It bleeds. It is nothing but pyogenic, but it is called as pregnancy tumor, which is histopathologically called as angiogranuloma, purely because of hormonal imbalance. You can attribute everything in pregnancy because of hormonal imbalance. There's a lot of disturbance in the hormones, lot of issues with the hormones because of which it happens. So what you need to understand is whenever there is a hormonal imbalance, the estrogen progesterone levels will increase, right? Estrogen progesterone levels will increase, and these will have receptors on gingiva. Main reason is so these, and then P intermedia. The most common bacteria which is found in pregnancy is P intermedia, Prevotella intermedia. Prevotella intermedia predominates a lot in the gingival sulcus. Why? Because it needs vitamin K. So basically, vitamin K is there, which is menadione. This is also given by the hormones. That is why pre-intermedia dominates, and that's how the disease happens. You understand that how the conditions will happen. If you need any clarity, you can ask me later. Then the next thing is the management of the pregnant patient. This is also an additional point for the students, that how do you manage, and many professionals are very apprehensive actually when the pregnant female enters your clinic. So other than a good plaque control, you just do not want to do anything. But then yeah, you can do a prudent knowledge is necessary. You have to go for an elective dental care, and only if possible during the second trimester. So you cannot do it. Any emergency, okay, first and third trimester, but otherwise the ideal time is the second trimester as the safest zone or safest period. Prolonged chair time may need to be avoided because woman is very, very uncomfortable and that is what it is called as supine hypotensive syndrome. When the woman is asked to lie down completely supine on the chair, it compresses the vena cava and it leads to supine hypotensive syndrome. So what is the precaution you take is make the patient lie down on the left side so that it is slightly elevated with a 6 inch soft wedge. See a figure, and ask the patient to lie down in a slight different way so that the vena cava is not compressed or not having the pressure, and which will not lead to any sort of compression and hypotension. That is very important. You can go for all the varieties of treatments, but considering that the antibiotics are avoided and you have to follow the drug category. Radiographs also be very careful. Second trimester is safest, as I said to you. LAs are good. You can give LA. Lignocaine is safe. It is metabolized by liver. Major oral and perio surgery should be postponed. Safety of the radiographs, avoid radiograph, but then if you want to take a radiograph because it's an RCT or a pulp involvement or something, you need to go for a good protection. You need to go for thyroid collar, lead apron, very strong, and most important, technically, high-speed films. You have got films, or you can use maybe E-film. High-speed films are used, and then you can take the radiograph but second trimester, but not first and third. I hope it is very clear that the drugs of FDA pregnancy are there. FDA pregnancy are there for the risk factors, and then it is not going to affect. Okay. Then what is the most important consideration is prenatal oral health counseling is necessary. You have to make sure that the prenatal counseling is also done. Why prenatal or antenatal counseling is done? To make the patient aware what is the condition, to make the patient motivate, to brush twice, to maintain, to come for checkup, and to make it mandatory. There are a lot of AAP reports which say that prenatal oral counseling is very, very important, and FDA has given a list. So I hope if you know that there are 3 categories of drugs. Drugs category A, B, and C. Drugs category A is safest, B is also safe, C is to be avoided. So your lignocaine, your penicillins, your paracetamol, all of them come under safe category of drugs. So you can give them. A good painkiller is paracetamol, a good antibiotic is amoxicillin. You have to be careful. You're not going to give any teratogenic drugs. It is not only for pregnancy but also for breastfeeding. You need to understand even that thing regarding the distribution and the prescription of the drugs. You can definitely give. There are people who ask whether can we give chlorhexidine? Yeah, you can give. Whether can we give hexagel for massage? You can give. Anything topical, you can give. They are not teratogenic. You can comfortably give them, but try to avoid. But what happens basically is after the parturition, most of the enlargement subsides. But if it doesn't subside, then you may have to go for excision. But then you have to go for excision, taking care of many things, maybe post parturition. That is something very important, which you all have to understand. Okay, so that is one thing. Then so they are the main precautions. And then the most important thing, one is could periodontitis affect the time to conception? This is something very interesting. Even I was trying to wondering around the reason behind it, but then yeah, the answer is true. Periodontitis affect the time to conception. So if a female is planning to conceive and the female has the disease, then unless she goes for the comprehensive periodontal treatment, the conception time may take a little more. Normally, whatever we plan, but then conception time increases. There are papers on this topic also. So this is something newer thing to add up that yeah, periodontal disease also affects your time to conception. It's called TTC terminology. So you have to use that. And then periodontitis will affect the time to conception. So conception has to be planned. So that's why we say antenatal counseling is mandatory. Most of the hospitals are going for antenatal counseling and evaluating the response of the patients, then asking them to go ahead with their planning. So that is one important.